Good evening, everyone, and welcome to this session of Your Fertility Guide, the Fertility Friends Foundation webinar series designed to provide expert insights and guidance on fertility-related topics. My name is Isabelle Lefebvre-Vary, and I am the Executive Director at Fertility Friends Foundation. We're so glad to have you here tonight for this important discussion on endometriosis and fertility on the last day of Endometriosis Awareness Month. Fertility Friends Foundation is a Canadian registered charity that offers grants to cover expenses associated with fertility treatments, such as IVF, egg and sperm donation, and gestational surrogacy. We are committed to supporting individuals and couples navigating fertility challenges, not just through financial assistance, but also by providing education and resources to empower you on your journey. Your Fertility Guide was created to bring together top experts in the field to share knowledge and answer your most pressing questions. Tonight's session focuses on endometriosis, a condition that affects millions of people worldwide and is often misunderstood when it comes to its impact on fertility. We're honored to have Dr. Cho from Olive Fertility in Vancouver here to help us better understand how endometriosis can affect reproductive health and what options are available to optimize fertility outcomes. Dr. Cho is a leading gynecologist and a fertility specialist at Olive Fertility, with extensive experience helping patients with endometriosis navigate their fertility journey. We're incredibly grateful for her time tonight and for sharing her expertise with us. A few housekeeping notes. This session will last approximately 1 hour. Dr. Cho will begin a presentation, and that will be followed by a Q&A session. We encourage you to drop your questions in the chat at any time, and we'll get to as many as we can during the Q&A. With that, I'm excited to hand it over to you, Dr. Cho. Thank you for being with us.
I'm going to get started. Let me know at any point if you can't see my slide or if you're having any troubles hearing my presentation. So my presentation today will cover some of the important things that we need to know about endometriosis, what it is, how it is diagnosed, and how it affects fertility, and what some treatments are. I wanted to acknowledge the land on which that we gather is the unceded territory of Coastal Salish people, especially for me living in British Columbia. These are the territories of the Musqueam, Squamish, Tsleil-Waututh nations. Our most important first question is, what is endometriosis? And endometriosis, as some of you may already know, is a chronic inflammatory condition where cells similar to those that line the inside of the uterus, called endometrium, grows outside of the uterus. It may grow on the fallopian tubes, the ovaries, other pelvic organs, such as intestines or bladder. Each month, as the uterine lining thickens in response to hormone to get ready for the implantation of an embryo, it is associated with hormonal shifts. When hormonal shifts occurs, then the endometrium, the normal uterine lining, as well as the endometriotic implants can also react to the same hormonal changes. When the pregnancy doesn't occur each month, the endometrial lining generally disintegrates and sheds, and so will the endometriotic implants within the pelvic cavity. When menstrual blood bleeding occurs inside the pelvic cavity, those are the issues that can lead to symptoms causing irritation, scarring, as well as cysts inside the pelvic organs. We know that endometriosis can affect up to 1 in 10 reproductive age women. It's one of the most common and least diagnosed chronic illnesses in women. And we know that from the onset of symptoms to average time frame to diagnosis can be as long as 10 years. So it can be a condition that's underdiagnosed in so many women. The true prevalence of endometriosis is overall uncertain because often definitive diagnosis requires surgical or direct visualization of the disease, which is not always accessed by everyone. In terms of symptoms, endometriosis can be most commonly presented in terms of pelvic pain. Most commonly is this symptom of dysmenorrhea, painful periods. Patients can also present with pain with intercourse, pain with bowel movements, with urination, and also generalized pelvic pain that's not related to menstrual cycles. More importantly, infertility is one of the known side effect or adverse effect from endometriosis. Up to 50% of infertile women have endometriosis. And in a subcategory of women with infertility called unexplained infertility, there have been studies looking at this category of patients undergoing surgical workup and treatment called laparoscopy. And it's been found that 4 in 10 of these women with unexplained infertility may have a diagnosis of endometriosis. This is in comparison to about 2% of women who undergo surgery without a diagnosis of infertility. So we can see that endometriosis can be strongly linked with infertility. There have been no clear mechanisms that have been identified to explain the link between endometriosis and fertility issues. There are several mechanisms that have been proposed, including distorted pelvic anatomy, changes in peritoneal function in the lining covering pelvic organs, endocrine or ovulatory abnormalities, and more importantly, impairment in egg and embryo quality. I just wanted to warn you that there will be some more graphic photos coming up. So if this is something that is triggering to you, please look away for the next minute or so. This is a case of very severe endometriosis that is seen through laparoscopy, a minimally invasive surgery, and you can see the significant scarring between the uterus, ovaries, and the posterior cul-de-sac involving the bowels. This is another picture of a very typical type of endometriosis called peritoneal endometriosis, where you can see that there's endometriotic lesions in the peritoneal cavity with associated scarring and changes in terms of the peritoneal function. So off of the graphic slides, in terms of risk factors for endometriosis, there have been studies identifying different associations that have been identified. We know that short menstrual cycles, having a first-degree relative like a mother or a sister with endometriosis, having low BMI, history of not having given birth in the past, early menarche, early onset of menstrual cycles, as well as uterine abnormalities can all be risk factors associated with development of endometriosis. We don't know the exact cause of endometriosis. There are several theories that could explain why endometriosis develops, one of which is that menstrual blood containing endometrial cells travel backwards during a menstrual cycle. So instead of having a period and bleeding outwards, the blood travels backwards towards the fallopian tube and into the peritoneal cavity. And when those cells travel backwards into the abdomen, they can adhere to the tissue inside the abdomen and continue to multiply and develop in that ectopic location. There's also other theories to suggest that perhaps there is transformation of the cells lining the pelvis into endometrial cells due to hormonal shifts, or maybe related to genetics. There is a strong suggestion that endometriosis is genetically related, given the fact that first-degree relatives, if you have first-degree relatives that have endometriosis, you're 3 to 10 times more likely to have endometriosis in some studies. Furthermore, endometriosis symptoms can start in very early stages of adolescence or young adulthood, and further supporting a possible link to genetic and an early onset of these symptoms. There's also other risk factors that have been proposed, but overall, there's no one risk factor that is 100% associated with the development of endometriosis down the road. One of the frustrating part of about endometriosis and diagnosis is that endometriosis can be very hard to diagnose. Number one, endometriosis can have nonspecific symptoms, things like pelvic pain, infertility, pain with periods. Those can be symptoms associated with other problems, and therefore, patients don't always know that these are symptoms of endometriosis. Secondly, there's stigma and symptom normalization, and patients don't often feel comfortable disclosing some of these symptoms to healthcare providers or other healthcare professionals. There's also a lack of awareness that some of these symptoms can be associated with endometriosis. And lastly, we know that there's no specific biomarker that tells you with 100% certainty that someone has endometriosis. Therefore, the average delay between the onset of symptoms and the diagnosis can be 7 to 10 years. And qualitative studies have consistently shown that when patients have delayed diagnosis, patients can experience many psychological negative outcomes, such as self-doubt. Is this all in my head? Isolation. I'm alone in this world with all of these symptoms and no one understands. Apathy and hopelessness. There's no plans to help me, not sure what my next steps might be. And fear about malignant disease, cancer, etc. So it's really important, and it's good that we're here today talking about these symptoms, talking about endometriosis, hopefully changing the tide on making endometriosis more recognizable and improving diagnostic frequency. In terms of tests for endometriosis, the first important step for evaluation for patients with possible endometriosis is a consultation with your physician or healthcare provider. A complete physical and history is important because we need to understand a patient's symptoms as well as their overall goals of care. Not every single person comes to us with the same goals. Is it pain management? Is it fertility? Is it anatomic disruption? What is the goal that we're trying to achieve for this patient? And it should be individualized. When someone presents with pelvic pain that's cyclic, chronic, progressive, and persistent, the diagnosis of endometriosis can often be more likely. In terms of physical examination, this can be a helpful early screening test to understand if there's nodule or any physical abnormalities that can easily be diagnosed. And imaging can also be helpful in certain cases of endometriosis for identifying things like endometriomas, larger nodules, or pelvic scar tissues or limited mobility in pelvic organs. There are specialized or advanced ultrasounds and advanced imaging testing that are specifically geared towards diagnosing endometriosis, and therefore speaking to your healthcare provider about your symptoms and trying to hone in on this possibility of diagnosis of endometriosis would be very helpful when they send off a requisition to try to understand more about how to do these imaging exams to allow for us to have a more accurate diagnosis rather than just a generalized requisition about pelvic pain. Lastly, a test for endometriosis could include surgery or laparoscopy because a lot of these endometriotic lesions are very small, superficial, and intra-abdominal. They sometimes are not picked up through imaging modality like ultrasound or MRI. Therefore, direct visualization with surgery and biopsy with a histologic diagnosis may be more relevant for certain patients for workup and diagnosis. With most contemporary approach to endometriosis diagnosis, we are encouraged to explore diagnosis in 3 separate varieties. The first way of classifying endometriosis is a clinical diagnosis of endometriosis, where endometriosis is suspected through history and physical, and possibly some degree of ultrasound, but there's no clear advanced imaging or surgical confirmation. But one can still have a clinical diagnosis so that they can have a preliminary diagnosis to start working on treatment. A second classification of diagnosis would be an imaging diagnosis of endometriosis. That's when there's some degree of symptoms or no symptoms, and there's advanced ultrasound or MRI that is able to determine if there's endometriomas or deep endometriotic nodules present. And this would give you an imaging diagnosis of endometriosis. And lastly, and probably historically the most gold standard of diagnosis for endometriosis would be directly visualizing endometriotic lesions at the time of surgery, and coupled by the support of a biopsy specimen showing endometriotic lesions also seen. So the most contemporary approach to endometriosis care is to establish a diagnosis in any or all of these categories as appropriate, and hopefully get the patient treatment and recognition of their condition sooner rather than later. And in terms of ultrasound findings, this is what an endometrioma might look like on ultrasound. It is a cyst that's generally filled with old blood product, essentially, or a product that resembles old blood product. And what you could see on ultrasound is this layered, cloudy appearance, which is a very characteristic finding and visual finding on ultrasound. This can also be seen on an MRI as well, but with slightly different imaging appearance. If someone undergoes physical, ultrasound, or surgical testing, we can also further classify the patient's type of endometriosis to superficial, where there's just small amount of endometriotic deposit in the pelvis or the ovaries or pelvic organs. Deep endometriosis is where there's significant scar tissue, tethering, adhesions between the pelvic organs as a result of endometriosis. And ovarian endometriosis, which is also called endometriomas. These are colloquially, often people refer to them as chocolate cysts, because when we remove these cysts, we have to rupture the cysts, and when we open the cysts, that layered appearance on the ultrasound is actually the blood product, and they come out kind of brown, which is why they're called chocolate cysts. Adhesions or kind of thinner scar tissue as a result of the chronic inflammation within the pelvis can also cause other problems, not just at the organs at which that they're attached, but leading to other issues for more fragile pelvic organs like the fallopian tubes. Endometriosis can also be found in the walls of the uterus. At that point, it's called adenomyosis, just a slightly different word for it. After extensive workup of endometriosis, often patients are given a stage. The stage speaks to the severity of endometriosis that the patient has. Historically speaking, this classification of staging is with the American Society for Reproductive Medicine guideline, but a more up-to-date directives or up-to-date scoring system has been presented, looking at the exact location of the endometriotic deposit, looking at the amount of abnormal tissue that is present, and looking at the absolute scarring within these different areas in the pelvis. And when someone has surgery, they can absolutely visualize through all of these different areas inside the pelvis. The surgeon can come up with a absolute score that will reflect the severity or the stage of endometriosis. Unfortunately, the challenge of this type of staging is that it does require surgery to have a very clear or definitive stage that is found, even though the stage of endometriosis or understanding of the stage can often correlate with pregnancy success, and therefore we give us information in terms of what is a patient's prognosis for natural conception. Sorry, there's some more graphic photos coming up here as well, looking at endometriosis. So if you're squeamish, please look away and I'll let you know when the images are completed. So this is a classic type of endometriotic lesions, white scarred lesions around the uterus, very close to the ureters and close to the ovary. This is another image for another patient where some thinner adhesions have formed between the pelvis and the uterus and the ovaries, as well as the bowels. This is a picture of the chocolate cysts or the endometrioma. At this time, looks like the surgeon is trying to drain and remove the cysts. As other pictures of endometriosis involving the bladder, the uterus, different areas of the pelvis, causing endometriotic nodules. Overall, there are many reasons why endometriosis can affect fertility and cause symptoms. When you look at these images, it's quite clear why these symptoms can occur. So I'm done with the photos there. If anyone is squeamish, you can come back to the slides. In terms of the management of symptoms associated with suspected or confirmed endometriosis, generally, the patient's goal of care is the priority for us to understand what is the best next step of treatment. The reason for this is because a lot of the medical treatment for endometriosis is not unfortunately not permissive for pregnancy. So when you're on continuous birth control pill or progestin or GnRH agonist like Lupron, this patients cannot try to conceive while they're on medical suppression. This is why if we understand that if the priority is mainly symptom control versus fertility, you're a doctor and you will decide what is the best next step for treatment. Again, the treatment of symptoms related to endometriosis needs to be individualized, but it can include complementary therapies or lifestyle changes. It can involve just symptomatic pain management with anti-inflammatory medications or opiate medications if really necessary. It can include hormonal medications, surgical options, as well as fertility treatments. In terms of complementary therapies, the BC Women Center for Pelvic Pain Clinic is a tertiary referral site for, at least in BC, and I apologize that I don't know your local resources if you are not from BC, but the BC Women's Center for Pelvic Pain is a tertiary referral clinic at BC Women's Hospital in Vancouver, and it is a site where physicians will refer patients with really severe pelvic pain or endometriosis to, where they can have a very holistic and comprehensive multidisciplinary care. And at this clinic, they will work with patients on pelvic floor physiotherapy, counseling, pain and neuroscience education. They will advise on acupuncture, the use of TENS machines, and these are all evidence-based options for pain management. Of course, exercise, a optimal diet, and optimal sleep can also influence and improve someone's perception of pain, and that's also recommended through the Center of Pelvic Pain Clinic. We know that dietary-wise, there are certain foods that can be pro-inflammatory and other foods that may be helpful in terms of reducing inflammation. It's suggested to use multivitamins that can help decrease the inflammation or is associated with lower inflammatory mediators and hopefully reducing some pain symptoms for patients. Dietary reminder to use more fruits, vegetables, and less processed foods. However, when lifestyle interventions do not completely reverse your symptoms, then medical management is required. If someone has fertility issues, then our best option would be trying to improve either spontaneous conception or consider assisted reproductive treatments. For patients in British Columbia, and I apologize if I don't know your local resources, but for patients in British Columbia, if you present with infertility and endometriosis, we would see you at our clinic at Olive Fertility Center. The first part of the consultation would be a history, complete consultation with a physical examination, and also fertility testing, looking for issues with ovulation, ovarian reserve, fallopian tube patency, as well as abnormalities with the sperm. This is a type of test that looks at fallopian tube opening or patency called the hysterosalpingogram, where a patient would present to a radiologic suite, and usually at the hospital, and some contrasts will be placed into the uterus, and they'll take a picture to see that the contrast is able to flow normally through the fallopian tubes. Again, endometriosis can affect fertility with some unclear mechanisms, and we suspect that there's some impact on egg or embryo quality, decreasing fertilization rate, changing peritoneal fluid uh, components, any abnormalities in the uterine contractility and receptivity, as well as structural abnormalities within the pelvis. Those are all researched to be possible causes of endometriosis. However, there is not one theory that is consistently found across all studies. There is a immunohistochemical test that can be done called the Receptiva to diagnose or give more understanding of whether or not someone has endometriosis without surgery and without some of the imaging and histologic symptoms or signs. This test is looking for this proto-oncogene called BCL6, which is a specific genetic component that can be associated with inflammation. The way that we can organize this test is to sample the uterine lining, do specialized staining on the tissue that's obtained from the uterus, and understand if your uterine lining overexpresses or underexpresses this type of gene. If the BCL6 level is found to be high in the uterine lining, then there's been studies to suggest that the patient has a higher risk of endometriosis and should consider certain interventions to improve chances of success before an IVF cycle or treatment. So this is a non-invasive or less invasive way, I suppose, of diagnosing endometriosis when you don't have any imaging or histologic signs of endometriosis. In terms of the options for fertility treatment, I'm just going to go into this very briefly in the interest of time. But endometriosis treatment can involve basically stimulating the ovaries with pills or injections, coupled with intrauterine insemination, where sperm can be concentrated, debris removed, and taken up through a catheter and placed through the cervix into the womb as close to the releasing egg as possible to help the egg and the sperm meet. Patients can also consider in vitro fertilization, which is a more definitive option for fertility treatments. For patients with infertility, surgery can be a reasonable option depending on the patient's specific characteristics. The benefit for surgery for us in British Columbia is that this is covered by MSP, and it can, in some patients with endometriosis, improve the chances of natural conception. There is a randomized control study that was published in 1997 called the EndoCan study, They randomized patients to so they had patients with endometriosis, and they either randomized patients to just looking with a camera versus actually looking and treating and removing the endometriosis when found. And they found that when patients had the laparoscopic surgery, there is a higher chance of natural conception after the surgery is performed. It seems to plateau, the benefit seems to plateau after about 30 to 36 weeks post treatment, post surgery. However, the treatment effect it is present, but it's not great. For every 8 person that was treated with surgery, there's only one improvement in terms of chance of pregnancy. So surgery can be reasonable and effective for patients who are not ready or needing to do more definitive fertility treatment like in vitro fertilization. They should be considered for patients who have pain that affects their quality of life. They should be considered for women who are younger, shorter durations of infertility, or have very high prognosis with natural conception because they've had another baby in the past. If patients have one-sided or bilateral or both sides of endometriosis, and you have to remove the ovarian cysts, but the egg reserve otherwise is good. So you're not worried about surgery removing and decreasing someone's egg number too significantly. And surgery can be considered for those who would not otherwise do IVF or any fertility treatment otherwise. Because for those patients, then there's not other better alternatives rather than surgery. Obviously, delaying fertility treatment may obviously have other risk factors, especially if patients have more advanced age, because there's the age-related infertility risk to contend with in the future. At a time of surgery, your surgeon can also help understand exactly what are some risk factors for fertility after the surgery is completed. This is a tool or a scoring system used specifically for us to document how endometriosis affect fertility after the surgery is completed. The surgeon would place different scores based on the amount of damage on different pelvic organs. And when patients have a higher score, then they have a higher chance of pregnancy without any further fertility treatment down the road. And if they have lower scores, then they have a worse prognosis with spontaneous conception down the road after surgery. So surgery may also help stratify patients in terms of their risk factors and their need for IVF treatment or assisted reproduction treatment. And again, after surgery, one can consider trying to conceive on their own, understanding the studies that have been done in the past, mainly observed patients for about 36 weeks or upwards to 1 year in another study. So generally speaking, try to have a discussion with your fertility specialist first about what is the time frame that makes the most sense for you based on your specific age, ovarian reserve, and other test results. But trying your own, if you're a good prognosis patient, would be a reasonable option. Or some patients might decide to go into intrauterine insemination or IVF treatment to try to conceive sooner and have a more successful treatment at a shorter time frame. In some patients, surgery may not be the best thing to do, and perhaps more definitive fertility treatment like IVF may be considered in these patients first, especially in women who are older, often have a lower prognosis with fertility treatments. If patients have a long duration of infertility, can more often predispose them to needing IVF treatment at some point. If patients have lower ovarian reserve or egg numbers, because surgery can impact ovarian reserve. If patients have had previous surgeries for endometriosis, but still not conceiving within a reasonable time. if there's known structural abnormalities, or if there's sperm abnormalities that is known. In terms of IVF treatment, IVF takes about a month and a half for the egg retrieval process and the ovarian stimulation process. The first month is priming, trying to synchronize the follicles and the eggs. Next month is injection phase. The injection phase lasts about 2 weeks. It's we think of the injections as food for the follicles, for the little eggs. And we hope to give enough food for the eggs so they all grow, hopefully at the same rate at the same time. And with vaginal ultrasounds, we can monitor how the eggs are growing. Once the eggs become a more mature size range, we organize an egg retrieval procedure where a transvaginal ultrasound guides a needle through the vagina into the ovaries to remove the mature eggs that you've grown. Once the eggs are retrieved and they're looked at under the microscope, we can either fertilize the sperm and the egg together by helping the sperm and the egg meet, or just allowing the egg and the sperm to meet in the petri dish. Then we would grow the embryos out in the lab until they make it to a mature stage, and then transfer the embryo back into the womb for pregnancy. This is a image of what a egg retrieval might look like, with a vaginal ultrasound guiding a little needle through the vaginal wall into the follicles, a little home that hopefully contains one mature egg. And each follicle is entered, and the eggs are then removed through a suction tubing into a test tube, and then the embryologist or the laboratory staff will look through the fluid with a microscope to identify the eggs. Once the eggs are retrieved, then they're fertilized with sperm. Within a week, we should see a healthy embryo called a blastocyst. This is what it typically looks like, but of course, depending on the egg quality, sperm quality, we can see abnormal blastocysts that have a less optimal feature and therefore associated with lower pregnancy rates. With IVF treatment, when the embryo becomes a blastocyst, about a week old, the embryo can be biopsied. We would take 5 to 10 cells from the part of the embryo that eventually will form the placenta. That part is called the trophectoderm. And those cells can be analyzed genetically to understand if the embryo has the right sets of chromosomes. If the embryo has the right sets of chromosomes, they're associated with a higher chance of pregnancy compared to embryos that do not have the right sets of chromosomes. This way, we can help select the embryo to put back into uterus first to help achieve a pregnancy faster compared to transferring an embryo that did not have the normal sets of chromosomes. In terms of the next steps after an embryo is created, usually after that is the frozen embryo transfer. It could be fresh embryo transfer as well, where the embryo is placed through a little catheter through the cervix into the womb at the right place, guided by a vaginal ultrasound. The difference between a fresh versus a frozen embryo transfer is basically the time at which you do the transfer. A fresh transfer is occurring at the same time, around the time of your egg retrieval. So about 6 days after the egg retrieval is completed, you transfer the embryo back in. A frozen embryo transfer is the more commonly used approach because we allow your body to return to normal, allow all of the inflammatory mediator, the estrogen level, the blood product to be resolved from your pelvis prior to putting an embryo back into the womb after a treatment of uterine lining preparation. If someone has endometriomas and they are hoping to get pregnant, sometimes people wonder, well, these cysts are present. Do we need to remove them? Often, we don't recommend removal of endometriomas, especially if someone is undergoing IVF treatment. But depending on a person's symptoms, age, ovarian reserve, duration of infertility, and type of treatment they're hoping to undergo, it may be warranted. So it would be something to talk to your physician about. If you have endometriosis or endometrioma and you're not ready to get pregnant, then hormonal suppression would be the best option, because what we want is to help stabilize endometriosis and prevent further growth. We do not want any further development into further scarring, further nodules, further ovarian endometriomas, and we want to preserve as much ovarian reserve as possible. If you're not ready to get pregnant right away, it's always a good idea to start thinking about family planning. And again, nothing is a must, but it would be wise to start thinking about, when is it that I want to get pregnant? How many children would I like to have? Who do I want to have children with? And would I consider freezing some eggs to improve my odds in the future? There's just different ways to come up with a most optimal plan for yourself. But of course, you have to start thinking about what your ideal situation is in order to, uh, have a realized plan that can be followed. But you can always ask for a referral to a fertility specialist, because this is part of what we do. We treat infertility, and we also help patients learn about their options with egg freezing, embryo freezing, and even conceiving on their own. In terms of fertility statistics, it is important to know that as a woman's age increases, natural conception rates decrease. So that would be the case even if you have endometriosis or without endometriosis. So age-related fertility statistics are important to keep in mind as you consider family planning. We know that when patients are not ready to get pregnant, they can consider doing egg freezing. And when egg freezing is performed, it's similar to the IVF treatment that I mentioned earlier, but instead of having sperm and fertilizing an egg and the sperm together, the eggs are just frozen as mature eggs. What we see is that based on the age of the patient when they come in to have egg freezing, as well as the number of eggs that they can freeze per cycle, or depending on how many cycles someone tries to do to bank more eggs, it's associated with different odds of pregnancy using those eggs in the future. So, for example, if someone's between 35 to 37 years old and say they have a good egg number, like we expect around 10 eggs from their ovaries, then there's a very high chance of pregnancy when you come back to use these eggs. But some patients may come with a lower egg number. And for those patients, they may need multiple cycles to bank more eggs to get to that chance of security, or the probability of pregnancy using those eggs in the future. If you want to have one child, then this would be the graph that would be applicable for the patient to consider when they think about egg banking. But if someone is hoping to use their eggs for, say, 2 or 3 children, you could see that you need a lot more eggs in order to have a higher odds of achieving that family size that someone wants. So it's always helpful to start thinking about family planning, even if you don't have immediate plans to conceive at the moment. Um, I wanted to end the conversation and the talk with some toolkits and some more information that you can look into should you like additional information on specific topics. This is a list of different links provided by the Society of OBGYN of Canada. These different links focus on neural pain education, pain self-management, anxiety and depression. So these would be good ones to explore. There's also additional information at the BC Women's Centre for Pelvic Pain and Endometriosis. Again, from the SOGC, or the Society of OBGYNs of Canada, from the American Society of Reproductive Medicine, as well as some more information about self-care and physiotherapy. So thank you so much for being here today. It is a honor for me to be invited to talk about this very, very important topic. I really appreciate everyone's attention to this. Hopefully we can learn more about the condition, raise more awareness, and hopefully reduce the time from symptoms to diagnosis for patients, and hopefully decrease the stigma to this condition as well. So I welcome any questions you might have. And I don't know if Isabel has been gathering these questions for me, and I'll try my best to answer your questions. Just know that it would be helpful to not put anything too specific about yourself in the question, and I'll try to make it so it's less directed, just because, you know, I'd like to give you helpful information, but whatever information I give today will not replace the advice for your physician. So I do recommend that you follow up with your physician if you had any specific personal questions.
Thank you very much, Dr. Cho. It was a wonderful presentation, very
Thank
thorough.
you so much.
And we got a few questions actually.
Perfect. Great.
So I will start with some of them you answered throughout your
Oh, great.
presentation. So
Hmm.
if I pass it for the people who can see it in the chat, but you really want to have it answered, please ask again. But I will try to go through all of them. So first question, could you please describe the sensation of pelvic pain caused by endometriosis?
Yes. So pelvic pain caused by endometriosis can be described as sharp or dull or neuropathic, kind of like aching, or even electrical. The severity can be nothing at all. You can have no pain and you could still have endometriosis, or you can have 10 out of 10 most severe pain every month with your cycle. That could still be associated with endometriosis. It's a disease associated with a spectrum of different presentation. So there's not one appropriate description for the pain that someone may experience. But for the most part, the most common symptom would be severe pain, 6 to 8 out of 10 pain. And it depends on whether or not the patient has normalized the pain or not. But most patients would be moderate to severe pain associated with their period, lasting around the time of their periods and associated with other symptoms like pain with peeing, pain with intercourse, pain with bowel movements, etc.
Thank you very much.
Hmm.
How does endometriosis affect fertility and conception at geriatric pregnancy ages without prior pregnancies?
So it won't, endometriosis affect pregnancies in those different mechanisms that I had mentioned in the past. So one of the most concerning things would be a physical or a anatomic disruption to the reproductive system, so blockage in the fallopian tubes. They can also affect the actual quality of the eggs. And there's some theory that the more inflammatory environment which the eggs are growing in can affect the egg quality as well, changing the IVF outcomes, even with fertility treatment. I don't think there's a distinction between age in terms of the severity of endometriosis effect. So whether or not you're geriatric or non-geriatric in your age, endometriosis can still affect the natural fertility of a patient. I hope that answers your questions.
Is adenomyosis related to endometriosis?
Yeah. One of my previous slide talked a little bit about the different manifestations of endometriosis, and adenomyosis is another subcategory of or a related cousin of endometriosis, is endometrial glands invading into the walls of the uterus rather than depositing in the peritoneal cavity. So they can be closely related in that way.
Thank you. Would someone with recurrent pregnancy loss and silent endometriosis be a candidate for laparoscopy excision surgery in BC?
Yes, that's a really good question. So, if someone has suspected endometriosis, then it's always something to talk to your physicians about your menu of options, right? And surgery for diagnosis and treatment is one of them. Um, Generally, surgery is done for patients with infertility rather than for recurrent pregnancy loss, though.
You. Does the presence of small endometriomas, 1.5 centimeters, indicate advanced stages of endo?
It depends on the staging algorithm or classification that your physician uses, but generally it wouldn't be considered advanced. based on the more up-to-date staging mechanism. But again, I would recommend if you've had surgery to review that with your surgeon and your gynecologist to review that information a bit more.
Would be more beneficial to do a laparoscopy to determine the stage you may be in before starting Lupron and letrozole.
It's again, it really depends on your goals of treatment, and I'm not quite clear on that question whether you're starting Lupron and letrozole for symptomatic management or for fertility. Um, if you're starting it for symptomatic management, then I don't believe that really would be that beneficial. Um, if you're starting it for, if you're
Residents of
starting
Suffolk County, the commissioner and I say to them that
Oh, sorry. I think that might have been just some feedback or accidental mic turning on. But no, I don't think usually for starting medical treatment you have to do a laparoscopy. But I think it would be a question directed at your physician to understand what is the goal of laparoscopy? Is it to manage pain? Is the pain not well controlled with Lupron and letrozole? Or are you hoping to improve access to your ovaries for IVF treatment? Or so goals of therapy should be reviewed, but I don't think, based on your questioning, that it likely is necessary before you start medical treatment.
Is it okay for someone with endo to take melatonin nightly for a long period of time?
Yep, that should be reasonable.
Yeah. Um, what FET protocol would you use for someone with endo? Letrozole plus Lepron added immune protocol?
Yes, so for patients with endometriosis and hoping to undergo a frozen embryo transfer, there are certain protocols that have been associated with higher chance of pregnancy, including a suppression protocol, especially if they have an endometrioma. Um, Added immune protocol is not necessarily well evidence-based, but depending on your specific scenario, may be added.
Can AMH improve with surgery or any type of fertility treatment?
AMH, unfortunately, is a marker of someone's ovarian reserve, the amount of eggs that's left over in your ovaries. All of us lose eggs over time as we get older. It's a marker of ovarian aging, essentially. Unfortunately, there's no strong ways and evidence-based ways to revert your ovarian age from a older age to a younger age. So there's no medical or surgical ways of improving AMH definitively.
What is the, we have two questions, I think, about the government-funded cycle in BC.
Oh, yes.
What is the wait list like for government funding of one round of IVF in BC?
So it's a very good question. The
Mhm.
challenge for us physicians on the ground is that there's very limited information from the government about how to apply for the funding, who is eligible for the funding, and exactly what the time frame the funding will be allocated. We know that the application process is tentatively to start in July of this year, so it is coming up. But it's been pushed back from the initial announcement of April. We are grateful that it is still going through, knowing that there is a lot of different world and nationwide events that's happening with regards to trade wars and such. So there is information to come, but much of it has not been fully determined yet in terms of what the waitlist will be. So if you're interested in learning more about the funding, the best thing to do is to get yourself referred to a established fertility clinic in BC. Generally, the current existing fertility clinic will likely be, I think, participating in the government funding. And if you have a consultation beforehand, your investigations beforehand, um, I think that would put you in the best position to have the funding when it does come into play. But I don't know the details of exactly where, when, and how, unfortunately.
Do you know, the other question that we got
Mhm.
is if the IVF program in BC will cover future egg freezing and or embryo freezing? Do you know that? No.
So it's very clear actually on the government website. So if you look up IVF funding, British Columbia, you would find the first page from the British Columbian government. And unfortunately, it's very clear that it does not include coverage for fertility preservation.
Okay.
So if your intention is to preserve eggs or embryos for the future use and not to become pregnant right away, then it would not be eligible. You would not be eligible for the funding.
Dr. Cho, thank you so much for sharing your expertise with us tonight. This has been an incredibly insightful conversation, and we truly appreciate your time. And to everyone who joined us, whether you're personally affected by endometriosis, supporting a loved one, or just here to learn, we hope you found this session helpful. Fertility Friends Foundation is here to support you, not just through education, but also through our fertility grants. Our grant application platform opens tomorrow at 12 p.m. and will remain EST, 12 p.m. EST, and will remain open until April 30. During this month, you'll be able to apply for one of our grants. If you want more information, go to our website, www.fertilityfriendsfoundation.com. And if you'd like to support our mission, there are a few ways you can help spread the word about our grants and resources. You can make a donation through our website to help us fund more grants. And you can participate in our ongoing fundraising initiatives. At the moment, we have a raffle that is unfortunately only open to people residing in Ontario. And we have an online auction as well. Both of them, the raffle and the online auction, will close on April 7, which is next Monday. And lastly, you can mark your calendars for our next webinar. It's going to be on April 22nd at 7 p.m. EST with Dr. Prati Sharma from Create Fertility. And it's going to be a session about Fertility 101, understanding your options and when to seek help. And we'd love to see you there. Thank you very much again, Dr. Cho, for this amazing presentation, and thank you all for being part of this community. Have a great evening. Thank you.
Thank you, everyone. Nice to meet you all.